To today's webinar. Thank you for joining us. We are excited to have you today for the first of our content-based webinars for the VISTA Member Learning Network. Today we'll be focusing on the history and scope and scale of the overdose opioid epidemic here in California. Before we get started, I just want to go through some brief housekeeping instructions. If you do have any technical difficulties during the webinar, this is the number that you have on your screen to call WebEx for assistance, so please use that number if you're having any trouble. And we have disabled the chat feature for this webinar, so if you'd like to submit questions to us, please use the Q&A box that's on the right-hand side of your screen, and be sure to send your questions to all panelists, so make sure you select all panelists. So our desired outcomes for today's session is to provide you with an understanding of the history and scale of the opioid epidemic in California. You'll be introduced to a number of evidence-based strategies that are being put in play to lower the overdose death rates. And you'll also learn about system change efforts that are happening across California with your coalitions and systems level changes at the state overall all around opioid safety. So before I pass it over to our speaker, Kelly Pfeifer, I just want to remind you all that the California Opioid Safety Network really is a strong collaboration that we have with the California Healthcare Foundation, where Kelly is based, and you all as AmeriCorps VISTA members, and then our team here at the Center for Health Leadership and Practice at the Public Health Institute. And so we're really honored to have Dr. Pfeifer here today to provide this presentation for all of us. Kelly has been a really phenomenal leader in the opioid safety movement across the state, really galvanizing partners and really working together to improve the conditions of opioid safety and misuse around the state. She is the director of the California Healthcare Foundation's High Value Care Team, which supports policies and care models that align with patient preferences, are proven effective and affordable. She, in 2017, was the recipient of the Beverly Myers Award for the California Department of Public Health for her work in addressing the opioid epidemic, which is the agency's highest annual award given to an individual exhibiting outstanding leadership in public health. So really kind of impressive leadership that she's done there. Prior to joining California Healthcare Foundation, Kelly was the Chief Medical Officer for the San Francisco Health Plan, which is a Medicaid health plan, and Medical Director and Family Physician at the Petaluma Health Center. She's also served as a medical director for the Redwood Community Health Coalition, which is actually one of the participating opioid safety coalitions in our network. It's also worth noting that Kelly really helped launch and found this coalition network that we're all a part of. So we have a lot to thank her for in all this work getting underway with coalition-based efforts in California. So with that, I'm going to pass it over to Kelly for her presentation on getting to zero overdose deaths in California.
Well, thank you so much and welcome, VISTA members. I'm so excited to have you join our network and to be part of this work because we can't do this without you. I deliberately titled this talk, Getting to Zero Overdose Deaths, because every single overdose death is preventable, and any one of us who's been personally affected by the opioid epidemic knows how personal this feels, because even though more people die from alcohol and tobacco than die from opioids, neither smoking or drinking is going to kill you in your sleep tonight. Smoking or drinking very rarely kills a young teenager experimenting for the first time at a party, or someone with chronic pain trying to do the right thing and take the medicines that they think are safe. So that's really what's been so devastating about the opioid epidemic is how young people are when they overdose and die and how decades of life are lost. I often start talks by talking about my own experience, because I am a family doc, and I was trained in the era where we were really pushed to prescribe opioids for all kinds of conditions that our previous generation would never use opioids. Like when I was growing up, you would never get opioids for getting a tooth pulled or a sprained ankle, but when I was trained by drug companies and our medical boards and all the regulatory agencies and all our specialty societies were really pushing us to see an epidemic of pain, and that were telling us, we learn now wrongly, that opioids were safe when prescribed in high doses, at doses that we used to only use in hospice patients, and were safe when used long-term, and were safe when used for relatively minor conditions. So these are the painful lessons we've learned, and as a doctor, lessons that I saw face-to-face when patients I thought I was helping were getting worse and worse. And I got a call from the coroner one day from about a young woman who was holding my pill bottle in her hand when she died. So a lot of us have had these wake-up calls, and we've realized we need to do things differently. So there is some things to be reassured about in California. When you look at the overall U.S. death rate, it jumped 21% from 2015 to 2016, and our overall death rate in California has been pretty flat. And I do think that's because we've been working so hard over the last few years to try and make sure treatment's available and to try and do safer prescribing. And when you look overall at the rates, where the U.S. rate is 19.8 deaths per 100,000 people, our California rate is about half of that. And again, U.S. going up by 21%, and ours has been pretty flat, maybe trending down slightly. But the overall California rate, to be honest, is a little misleading because half of California lives south of the Burbank Airport, which a lot of people don't realize, which means when you tell the story of the average Californian, you're really telling the story of LA and San Diego, and you're not telling the story of our rural north. And the opioid epidemic in California has really differentially hit different parts of our state, with the rural north being the hardest hit, where some of our death rates in these rural northern counties that are to the left in blue are fairly close to what we've seen in Kentucky and Tennessee and these other states that have been hit so hard. The other story that's not told publicly is that this is not just a white epidemic in California. In San Francisco, for example, where I live, the death rate is 3 times as high for African Americans than it is for whites. And so in the urban environments, this is definitely not a white epidemic. And across our state, Native Americans are hit far harder by the opioid epidemic than others. So I really encourage you to check out our dashboard, and I'll showcase that in a bit, because you can find fascinating data about the part of the state where you're going to be working and learn about what's happening over time in that county related to prescribing and deaths and emergency department visits. So I could speak for an entire hour about how we got here because it's complicated. It's very much a blame game out there where everyone wants to blame the doctors, many people want to blame the patients, everyone wants to blame pharma. There's a lot of blame to share around, but it's a very complicated epidemic, and I think it's useful to highlight there's really 4 major drivers. And it's certainly, as a physician, I need to take ownership that I was part of this. The more we prescribed, which was in the green line, the more people died. And we've been learning more and more about how the more you are exposed to opioids, your risk goes up of addiction and even overdose death over time. We also know that the epidemic is shifting. It's less about pills, and we've been dropping our prescription pill death rate in California, and it's more and more about heroin and fentanyl. And fentanyl is so particularly devastating because a tiny little amount in a pill that you swallow that may look like an innocent Xanax, and this is happening a lot with kids, or that might be mixed with cocaine or heroin without the drug user actually knowing this, a tiny little amount can be fatal. And so you can see in these vials that the amount of heroin that it takes to create an overdose is much more than the amount of fentanyl, and that's what makes it particularly dangerous. On the bottom left, this has been called an epidemic of despair, and there's an amazing book called Dreamland that I encourage you to read if you have time. And it really tells the story of why this has just taken hold in rural America. much faster and why it's getting so much of attention. And so, you know, people will say, and I think fairly, that there's so much money poured into this epidemic because the face of this epidemic publicly is a Caucasian face, and addiction and death have been criminalized in communities of color and urban environments for decades. And we've learned the hard way that the war on drugs and criminalizing drug users has failed. And what it meant is mass incarceration of people of color in prisons and jails, and no less drug use, in fact, far more. And that's really why the fentanyl is such a game changer here, because you can't use law enforcement to contain the fentanyl epidemic, because you can get a postcard from China that looks like an innocent picture of a butterfly, and you scrape that butterfly paint off and there's enough fentanyl for several lethal doses. So there's no way to secure our borders against fentanyl when it's coming in through shipments in the U.S. Postal Service and through dark web, and it's really complicated. So what it means is that we have to recognize that law enforcement alone is not going to solve our problems. In fact, we have to go all out to solve treatment, because until treatment is easier to get than street drugs, we're going to fail. So this little map in the bottom right corner was taken a couple years ago, where all of the red areas are areas without opioid treatment programs. And if you can remember the match of the death rate, that's a pretty close overlay of all the areas where the death rate's highest. So we do have our work cut out for us. So there are 4 evidence-based strategies, and I emphasize evidence-based because when there's a crisis, everyone wants to do everything, which some ways is good because it's a complicated epidemic and we need to tackle it in many ways at once. But we at CHCF are really committed to saying, focus on the things that we can prove will stop people from dying, because everything else may help or may not help, but we need to put all of our efforts in the things that we can prove work. So we know for sure that you can prevent people from dying if they never get started on the long-term path of opioid dependence and drug use. So there's a lot of efforts around trying to avoid new starts. So you're not using opioids for every sprained ankle, every tooth pull, using opioids in shorter duration, so 3-day supply instead of 30-day supply, and avoiding the really high doses that we've seen cause so many problems. We also have to take care of the people that we've harmed, and there's a generation of people who have become dependent on opioids through no fault of their own. They had chronic pain, they went to the doctor, they got medicines that they thought would help them, and now they can't get off of them. And we need to focus on the people who are taking high-dose opioids and who are taking opioids and sedatives, because those are the people at highest risk of death, and those are the people who need individual help with a doctor to slowly taper down. Some of them may never be able to get off opioids, but certainly they can get to lower, safer doses. And our biggest effort in California Healthcare Foundation with our partners across the state is treating addiction. And as I'll go into later, there's clear evidence that if you treat opioid addiction with medications, you cut the death rate in half. If you deny people access to medications, you double or even triple their death rates. Finally, until we can get enough treatment, until we stop prescribing so much, we need to use harm reduction to stop the deaths, and that means making sure people stay alive long enough to get into treatment. So that means using naloxone or Narcan and making sure that's available in the hands of people who might encounter somebody who has an overdose event. It means making sure needle exchanges are available so that people can get safe needles, and this also keeps the community safer by keeping the needles off the street. And we're even thinking in San Francisco about starting supervised injection sites, and I can go into those if we have time. It's just, again, a way to keep people safe until they're ready for treatment. So we have stats available to tell us how we're doing in each of these 4 areas. And if you go to this website, and if you can't remember, you just Google California Opioid Dashboard and you'll find it. County by county, you can find these great reports which show you all of the different data that I'm going to show you next. And it's really interesting to look at trends over time. So let's talk about the first category of evidence-based options, which is prevention. So first of all, if you can see at the top, we are down 38% in terms of overall prescribing. And by we, I mean California. This is overall California prescribing rates. And you'll see these described as morphine equivalents because one Norco is a different potency than, fentanyl patch. So we want a way to measure what's the total load of opioids that is descending upon the community in the form of prescriptions in each county. And all across California, we have really trended down, which is amazing. In the peak of the epidemic, we were prescribing 3 or 4 times as much as we did 15 years ago, so we're making really good progress. And the reason this matters is they did this interesting study where they looked at thousands and thousands of people who were given a prescription for opioids. And what they found is that for every single day that you take an opioid beyond 3 days, your risk of long-term use goes up by 1% a day. So there's a big jump at 5 days, another big jump at 30 days, where 30% of people who take an opioid for a full month are still using that opioid 2 years later. And that has been a real eye-opener for hospitals when they think about how many opioids should we give someone who has gallbladder surgery. And this is the work of a lot of coalitions, is how do you get surgeons and doctors and dentists to rethink this and realize that after most surgeries, most people need a day or 2 or 3 of opioids. They don't need 30 days. And that 30 days in their prescription bottle in their house may cause them real harm. So this next category is managing, and these are the people who are taking opioids for pain, who are at high dose and at risk of death. And we've done well there as well, because you can see in the upper right that we're down 50% from our peak in terms of the number of California residents who are on high dose. And by high dose, we mean over 90 morphine milligram equivalents, and that's roughly the equivalent of 20 Norco a day. So, it's a really high dose. And what we know is that when you take that much, in this bottom left, there's a study that shows your death rate by accidental overdose when you're taking over 120 morphine equivalents a day is 9 times as high compared to lower dose. And that death rate is 10 times as high when you add benzodiazepines. So benzodiazepines are like Valium or Ativan, and it's a particularly deadly combination to have opioids and benzos taken at the same time. So those are populations that a lot of the coalitions are looking at. How do you get doctors to help people who are dependent on both of these medicines to get them to safer doses? The third evidence-based treatment, and I would argue that the most important one for us to focus on, is treatment, because right now only 1 in 10 people needing treatment are able to access it. And so we're trying to make sure that everybody who needs treatment can access what we call medication-assisted treatment, and that means using medications and behavioral treatment together. And we're up 50%. So we look at buprenorphine, which is one of the medicines we can use for treatment. We are slowly increasing it across the state, but we actually aren't yet where we need to be, and there's still a big gap. And the reason this is so critical is there's been hundreds of studies showing this. And this little study, what it does on the left, you can see with methadone, when people were offered maintenance, the small bar is their death rate, and when they were forced to detox, meaning they could only use methadone for a couple months and they had to detox off methadone, their death rate was 3 times as high. And this study looked at, I can't remember, it was definitely thousands and thousands and thousands of people. I don't remember the exact numbers. Buprenorphine, the death rate doubled when people were made to detox instead of maintain. And this is a real painful truth, because a lot of us would like to say, why should you replace a drug with a drug? Shouldn't you be able to be clean and sober without medications? And the answer, if you look at a data-driven answer, is, well, that would be nice, but that's not what the data shows. When you force people to try and get sober without medications, the risk of dying doubles or triples, and that's absolutely unfair. We need to look at what really works. And in the case of opioid addiction, unlike other drugs, the combination of medications and behavioral health treatment is critical. And the reason this is so important, as you can see, the blue line in California is what we're doing with prescription overdose deaths, and that means dying because you took too many pills out of a bottle, and the fentanyl deaths. So we've been dropping our prescription overdose deaths, but as our fentanyl deaths rise, and that's again why we have to make sure treatment's available, because when you take fentanyl, sometimes you die the first time you try it. We have to make sure that that this trend doesn't keep continuing, because it's devastating the East Coast and it's just starting to hit California. So when we think about what we can do in California, there's really 2 big ways that, themes that I've seen that categorize most of the work that we're doing. And one is changing how we think about addiction, and the other is working in systems. So let me go through each of these one at a time. So thinking about how we should think about addiction, we often use the comparison to diabetes. So diabetes is a disease where there's the cause is just like addiction. It's a mix of genetics, bad luck, environment, and behavior. To prevent diabetes, you can do it by doing behavior change. You can do it by early interventions, because if you have early signs of diabetes, you can get it under control. But once diabetes is bad enough, and as I've said, once addiction is bad enough, long-term chemical replacement is the only thing that works because, and by this I mean insulin, because most diabetics in the end need to use insulin because their body doesn't produce enough. And we don't treat people badly. If someone needs insulin every day for the rest of their life, they get access to health care that will provide them that. And in a judgment-free way, we're very compassionate with people who have diabetes, even if they come in the ER after binging on birthday cake. But with addiction, there's so much stigma that someone can have a completely clean 12 months and have one bad day and have the force of law come down at them for making that one mistake. And because what do you lose if, as a diabetic, you have a bad day and your sugar goes up because you eat too many donuts? You know, you don't lose access to your doctor. No one says, I'm going to take insulin away from you because you, bad person, clearly can't manage it. We don't take children away. We don't have people lose probation if they're on probation from jail. We don't take their housing away. Their family doesn't abandon them. They don't lose work. And they don't lose their identity. You can be a well-managed diabetic and have bad days once a week, but on average you're doing fine, and doctors like me say, good for you, attaboy, you're doing just fine. But with addiction, none of these things are true. You can lose custody. You can lose your parole. People get kicked out of treatment programs. They can get kicked out of their housing. And what I think is particularly sad, if you were someone who considers yourself clean and sober for 5 years, and you have one bad day and you make one mistake, you lose your sobriety. And that's, I think, a mindset we need to shift, where if we really see addiction as the chronic chemical disease we know it to be, that like diabetes has behavioral components and environmental components, we will really shift how we treat it. You know, another longer conversation, and I would really recommend you all listen to the Addiction 101 lecture by Dr. Corey Waller, because it's a very profound way of understanding addiction. And I'm going to paraphrase very briefly. What he talks about is that the long-term use of opioids changes the part of your brain that makes dopamine. And dopamine is the part of your brain that helps you survive. It is the part of your brain that drives you to eat and drink when you're hungry and thirsty, that helps you connect with other human beings, that allows parents to take care of children even when the children are making them crazy. It allows us to do things that are really hard, that are good for us. It allows us to avoid things that feel good, that are bad for us. That chemical network of dopamine is absolutely required to do all those things, and it's destroyed by long-term opioid use, and sometimes destroyed forever. Sometimes people can recover that part of their brain after a few years. But what it means when you've been living with opioids, which floods your brain with dopamine and your brain does all these adaptations, is that when the opioids are taken away, you're living in a tempest. It really feels to people in the midst of addiction, in the cycle of craving and withdrawal, it feels like you're going to die. It feels like you'll do anything to survive. You'll do anything to get that drug to make you feel like you're not going to drown and that you're okay. So we shouldn't be surprised when people have terrible behaviors when they're in the midst of untreated addiction, because they feel that desperate, like day-to-day survival is the only thing they can focus on. And what medications do is they stabilize that dopamine part of the brain. They take people out of craving and withdrawal, and what it allows people to do is do the hard work of recovery, you know, reconnect with people again, plan, do things, avoid things that really feel good because they know in the end they're good for them. And so that's the neuroscience behind it, and I could quote a bunch of studies about functional MRIs to prove it, or you could go watch Corey Waller. But the bottom line is we know for sure that if you look at who is still in treatment 12 months after they start, if they have medications that stabilize in the brain like opioids, and these are called opioid agonists, methadone or buprenorphine, that your chance of being in treatment is around 3/4. And these studies really vary, and some of them, the higher numbers are in perfectly controlled settings, and the lower numbers, it may be more like 50% in the real world. But anywhere from 50 to 70% of people on methadone and Suboxone tend to still be in treatment, participating, doing well at 12 months. Vivitrol is a trickier medication because it blocks the effect of opioids altogether. So about 1/4 of people who try to go on Vivitrol just can't do it because they can't get through 7 days of no opioids, which are required. So the craving withdrawal is so horrible that they can't make it those 7 days. And there's a really high drop-off rate, too, so that people starting Vivitrol, anywhere from 10 to 30%, are still taking it, still in treatment 1 year, and the rest have dropped off. And so Vivitrol and naltrexone tend to work really well for people who have fairly robust dopamine systems. These are people like lawyers and doctors and pilots with licenses to lose. And it doesn't tend to work well with people without good social support who may have a lot of environmental triggers. So what we at CHCF and our partners feel is it's most important that all 3 medications be available to anyone who needs them, because every person is different, and methadone may be perfect for someone and bad for someone else, and Vivitrol may be the right choice for others. But the most important thing here is in red, which is 6% of people are sober at 12 months if they don't have access to any medications. That means 94% of people relapse. So if there were any other treatment program that failed, like if there was a drug that treated diabetes where 96% of the people failed at it, it would be malpractice to prescribe that. Yet there are treatment programs around California that don't allow people access to medications and that make people feel stigmatized and horrible for needing those medicines, and that should be malpractice. Every person has a right to the right, most effective treatment to save their life, and that's really our point of view, is to try and make sure all 3 drugs and behavioral health services are available for all. So harm reduction is really a concept that we've used in diabetes for a long time and other chronic diseases, and what it really recognizes is that people are not perfect and we're human beings. Drug use is going to happen. And for all of the fossil records we can find of original humans, there are evidence of mind-altering substances. We can't create people who will never use mind-altering substances, so we need to work on minimizing harmful effects. It also recognizes that there's a continuum of behaviors, and that some behaviors, like using dirty needles in the street with fentanyl, is incredibly dangerous, where using clean needles in a supervised environment is less dangerous, and not using needles at all and being in treatment is the best. And along that continuum, we should try and be moving people from one direction to another, not requiring perfection, and that our ultimate goal is not perfect abstinence as defined by a drug-free, medication-free existence, but we're trying to improve individual life and quality of life and community life. And then also we recognize that there's lots of factors that go into how people get into addiction and how they respond to treatment, including a lot of inequities in our system. And many of you know and are painfully aware that poverty, class, racism, sexism play a role in how well people can deal with harm. So this is the model that we're trying to do, and again, the fact that our fentanyl overdose rate has jumped up in the last year where we have data is our wake-up call that we need to do an all-out effort to make sure that we are doing everything possible. So let's talk about in California, what are some of those things we're doing to try and work in systems to create a safe network of treatment. So you, VISTA members, are proud participants in our biggest effort, which is the California Opioid Safety Network. 40 counties of our 58 counties in California are all participating. And we're super excited by this because this is, people are standing up and talking to each other from silos that have never talked to each other before. You know, law enforcement doesn't typically talk with people from hospitals, who don't talk with addiction treatment, who don't talk with harm reduction and consumer advocates and families. And the way this worked is in 2015, we saw that San Diego and Marin had done an amazing job of bringing people together and making concrete 12-month action plans. So our goal in 2016, when the California Healthcare Foundation put out a request for applications, is we wanted to say, bring people together, but don't make 10-year plans. We want one-year plans. We want you to actively think, what can I do in my community to address overprescribing, get addiction treatment available, get naloxone available within the next 12 months. And so we worked with these 17 coalitions. We had coaches and webinars and convenings, and over 2017 we did an assessment and found it worked. And I'll share that data with you. And that's when we reached out and said, we need some help. CHCF can't do this by ourselves. We put out an application, and the Public Health Institute just blew us away with their application, clearly was the best contender. And so in 2018, we worked with them to launch this new network, which you are now part of. And we're very excited to see what's going to happen this year as all of this energy goes into the coalitions across our state working together. These are very early data, but what gave us great encouragement is that the counties that had coalitions we were working with dropped prescribing faster than other counties, and that they increased buprenorphine, one of the addiction treatments, faster than other counties. So we do think that this model works. The next big efforts are run by the California Department of Healthcare Services, or DHCS. The Drug Medi-Cal Organized Delivery System is an effort to make sure that everyone in Medi-Cal, which is Medicaid in California, has access to every treatment that's medically indicated, no matter what their addiction, no matter how severe it is. So all of these counties in orange are actively planning to implement these programs. So no longer are you in a situation where you can only get methadone treatment if you're pregnant, or you can only get residential treatment for alcoholism if you're lucky enough to live in a place that has it available. Across California, we're really using the momentum of the opioid epidemic to make sure that no matter what addiction, no matter what your skin color, no matter where you live, you can find evidence-based treatment to meet your needs. Specifically for opioids on the right, the California Hub and Spoke system, for all those counties in the green, they're trying to recreate what we already have on the medical side of the house, which is a primary care and a specialty care relationship. So if I'm a primary care doc and I have a patient with bad heart failure, they can go to a cardiologist, and when they're stable, they can come back and see me. Likewise, we want to create a system where if someone has severe addiction that's complicated, where they really need to see someone every single day, they should go to a narcotic treatment program or a methadone clinic. But when they're stable and maybe they're using Suboxone and they don't need daily methadone treatment anymore, they can see a primary care doc. And we want to create a system where methadone clinics, now we call them opioid treatment programs, are talking to community health centers or clinics, and that where they're communicating and they're coordinating and they're trying to help patients get the right care. So this is brand new. It was based on a model in Vermont, and it's been launched in this last year, and we're really excited about it because not only is it working with primary care clinics and opioid treatment programs, but it's bringing in emergency departments and hospitals so that no matter where someone goes, that they can get treatment. This next big effort called Smart Care California is trying to get health plans and public purchasers, and by purchasers I mean Medi-Cal and our Obamacare exchange, Covered California, all together to pull in the same direction around the opioid epidemic. So this was started in 2015. There's a variety of activities that Smart Care California has done to try and get health plans and provider groups to do the right thing with the opioid epidemic, along with our other things we're working on, like C-sections and low back pain. And we've made some progress, and we're continuing to push this. Again, I don't want to spend too much time on it, but I'm happy to answer questions at the end. We also have a lot of federal money coming into the system, and so the California Department of Public Health, or CDPH, and the Department of Healthcare Services and our foundation are working together to spend this nearly $100 million to get more addiction treatment in place. And so one example of a creative way of doing that is to try and do learning collaboratives. So we want to get addiction treatment in all the jails, but it's really difficult to do. So we're launching a program this summer where jails can learn from each other and learn from jails in New York City and Rhode Island, where they've been doing this for a while, to figure out how you get addiction treatment into the jails in a way that works. Because when Rhode Island did this, they dropped the death rate after jail release by 61%. So this slide will be available to you, and we can go into more detail during questions if you like. And the final thing I wanted to mention is that there's so many efforts going on in the opioid epidemic in California. It's hard to coordinate them all. So the Department of Healthcare Services pulled in everyone in one room, from Department of Motor Vehicles to the Medical Board to DEA, Board of Nursing, health services, and we meet every couple months to coordinate all of our activities just to make sure that we're all working in the same direction. And the opioid safety network, so what you're working on, is part of that work group to make sure that they all know what you're doing. One question that often comes up is, how do you know what, how much treatment you need? Like, you're working in a local county like Lake County, how do you figure out if you have enough treatment for the demand? So we commissioned the Urban Institute to come up with these county-by-county snapshots, and we'll send you a link with this so you can have it. And it shows in that particular county how many people have opioid use disorder, how much treatment's available, and what's the gap, and what would it take to build that gap. And that's a real priority for the coalitions over this next year or two, is county by county, what's it going to take to make sure everyone who has addiction can get treatment. Because this is ultimately our vision. And if you get the slides and you click on any of these links, you can learn more about each of these projects. But Smart Care California is working with health plans to make sure they're doing what it takes to make addiction treatment available. We're working with primary care clinics, so doctors like myself learn to treat addiction. We're putting addiction treatment into emergency departments and hospitals, into jails and prisons. We've got a project we're working with residential treatment centers so that they stop refusing people access to medications and instead say medication use is welcome and you're welcome to come because we know that it's going to help you recover. So again, our vision is that anywhere you go, you can find the treatment you need, and because that's the only way we're going to drop deaths. We had another epidemic that felt a lot like this, where people were blamed for their disease, where people were dying right and left, and then in 1995, the AIDS death rate plummeted. And it plummeted for many of the reasons that we think we can control in California and in the U.S. We need access to effective medicines. We need a massive campaign to remove barriers to treatment, and we need to take the stigma away so people can get treatment without feeling shamed by it. And it's been done. In France, they did exactly this. If you look at this black line with those little diamond shapes, the death rate plummeted in France once buprenorphine or Suboxone was made widely available. Also a longer story, but the bottom line is that in the U.S., we're increasing death rates by 21%. France dropped it, and they did it by doing an all-out treatment effort. And that's where we need to go. So I'm going to save the last 20 minutes or so for questions, and I'll turn it over to my colleagues to help tee those up.